So I had a few slides on vaccination and things, but of course I didn't, I can skip over some of that stuff. But essentially, um, let's see here, for some reason, did that advance? Can you, I just want to make sure I'm advancing.
You're good.
Oh, good. Okay. So as most people in the room know, we have, in addition to the other pandemic that we have going on, we have an HPV related epidemic. And I guess technically it would be a pandemic because it is worldwide, but in the head neck world, we've had an increasing risk of oropharyngeal cancer. And if you look at this table on your left, you'll see that the rates of oropharyngeal cancer related to HPV are much higher than they used to be in the past. In the past, they were almost all related to smoking and alcohol use. And now the majority of cases, more than 90%, if you look at the global data, are related to HPV. And you can see the decreasing incidence of environmentally related tonsil and tongue-based cancer and the increasing incidence of HPV-related cancer. And if you look at survival data, HPV-related cancer confers a much better survival than HPV-negative or environmental cancers. And that's true throughout the world, but this is just some really high quality data from the Swedish Cancer Registry that shows you the magnitude of the difference between the survival. So it's a much better disease to have in terms of your survival. Now, there are a lot of molecular differences, even though they're both squamous cell carcinomas. HPV-related carcinoma has been well characterized in the cervical cancer world, and also this is also true in the head neck. We're starting to see more data about the basic drivers of E6 and E7. They have less mutated P53 as compared to the environmental, and it's more of a PI3 kinase pathway, et cetera. So it's a different disease. If you look at this CDC data, it's kind of interesting. There are a lot of gender and racial differences in the head neck world. Now, obviously the mechanism would be oral sex in an high-risk HPV positive male on female. And so the people that are getting head and neck cancers tend to be more males. Also, there's reduced, and they tend to be Caucasian males, and there's lower incidence in other racial communities, such as African-American communities or Asian communities. And that may be related to exposure risks, different rates of vaccination in different communities, and social practices. What's interesting to me is that we have about 80 million people infected with HPV, and about 0.4% of those in the US are high-risk HPVs. And some of those are cervical exposures and anal exposures, et cetera, but we really only see about 20 to 30,000 new cases of head and neck cancer. And so there's a lot of questions that are unknown about this cancer. Mechanisms, why do some infections persist when a lot of the infections or exposures occur early in life and get cleared by the immune system? And we don't really have a pre-malignant model like they do in the cervical world. So there's a lot more to understand about this disease, and it is different there are a lot of differences between other HPV-related cancers. So some of the work that we're doing here, and I'm working pretty closely with Marshall on a lot of these projects, and he's going to present some other data from his trials. One is a collaborative with Hopkins, Penn, and Oregon Health Science, and this is called the Mouse Study, and we're screening about 1,500 people. I think we have about 500 people already enrolled across the whole, across the 4 centers, to really look at patients who may have been exposed to HPV, high-risk HPV in the head and neck. And so their eligibility criteria includes number of sexual partners, et cetera. And then we collect urine, blood, saliva, and screen them for E6 seropositivity, and are looking for around 7% of those people that have chronic oncogenic high-risk HPV, and then we're going to follow them with MRIs and ultrasounds to see who develops any head and neck cancers and what their risks are. So it's a pretty large epidemiological study, and we're enrolling now, and that's, the enrollment has gone pretty well. You also answer a questionnaire based on all your behaviors, including smoking and partners, et cetera. So hopefully we'll have some preliminary results from that in about a year or so. So currently for us, we have this increasing incidence of these head and neck cancers related to HPV. A large number of the population is unvaccinated because the vaccine wasn't available at the time of the exposure. The vaccine strategy is expanding, and the estimates that I've read, if we have good implementation of vaccination, at least in, now this isn't worldwide, this is in America or North America, we can prevent about 90% of these cancers. Of course, getting the vaccine to everybody is very difficult. And we also know it has a better prognosis with standard therapy. But we have some other factors that we're looking into for head and neck in terms of that good prognosis. So we know patients who smoke and have HPV-related cancer don't do as well. We know there's some differences in the serotype. There's some recent data looking at HPV-33 in head and neck, and they did worse than the more common HPV-16 or 18. And if you look at our New York data that we published in 2016, in the New York area, about 9% of our population do not have HPV-16 serotypes. They have other types of serotypes, including 35, 33, 18. We've seen some 45s and 69s, et cetera. So we're in an interesting era where we have a vaccine that can prevent this disease, but yet we're seeing a rising incidence. And that's primarily related to the penetration of the vaccine, which I'm sure Dr. Diaz is going to talk about. But if you just look at the rate in men, currently it's about 7%. So we haven't gotten to the point where we're able to present all these diseases. So we're going to see a lot more of these cases. And while patients do better with chemoradiation, the problem is that chemoradiation is very devastating in terms of function, and that's due to the therapeutic ratio of the radiation. High doses will cure almost all of these cancers, but they also relate in a lot of functional morbidity with dysphagia and xerostomia. And so the other area of research that Marshall and I are going to talk about is de-escalation of therapy, or basically selecting therapies that have equivalent oncologic control with decreased poor functional outcomes. So, you know, if the survival rates for this early stage are around 90%, we want to minimize the toxicity. And for advanced stage disease, we want to maximize local regional control and reduce the metastatic rate. And so this is the SEERS trial that we're running. And I have a little results to present today that we recently presented in Arizona. And basically, this is a minimally invasive surgery trial where patients with early stage oropharyngeal disease undergo robotic surgery. And then we use the pathologic findings from the surgery to determine what adjuvant therapy they would get. And you don't need to pay attention to all this, but the highlight is that they're getting a reduced dose of radiation compared to standard of care. So standard of care would be about 60 to 66 gray. And we've dropped the dosages because of the good cure rates in order to try to improve the patient's function. And if you look at, we've enrolled about 100 patients. We have 55 that had sufficient follow-up so far, and here's the survival. And you can see within all three groups, regardless of whether they're in the low risk or the high risk group, their survival is very good on this trial because we're stratifying them based on pathology, and the worse their pathology looks, the more aggressive the therapy. So they're doing quite well, around 90 to 92% survival. And I'll talk about that. Their functional outcomes so far look excellent, and you can see that each of the three groups, in terms of dysphagia and symptoms, if you receive surgery, radiation, and chemotherapy, you do score higher on these scores, but they tend to, over time, they tend to normalize. And it's pretty encouraging that most people, in terms of their dysphagia and symptoms, actually over 6 months will really normalize to near baseline levels. So they're not perfect, but they're doing much better than what we see in terms of functional outcomes for standard of care chemoradiation. We did have 4 failures, and you can see the site of failures. We had some local failures, contralateral failure in the neck, and an ipsilateral neck failure, but all of these were salvaged.
Can you tell Christine to come to my office?
Sure.
So we had, 100% salvage rate, which was excellent. So that's one of the other problems is their survival curves are so good with so few events, it's hard to tell if we're doing the right thing sometimes. And I just wanted to show you this case because I think it's instructive of how we really don't understand this disease. So this is a 28-year-old female. She had a tonsillectomy because she was having some pain in her tonsils. And after the tonsillectomy, after routine tonsillectomy, they found in her pathology she had squamous cell HPV related. Now, remember, I told you it's relatively rare in a female, so she's already not fitting the window. So we enrolled her in the Sears trial, and here's her PET scan. You can see she has one node here, and then this is lighting up because she's had a recent tonsillectomy. And after surgery, we found that she had 10 positive nodes in her lateral neck and 2 retropharyngeal nodes. So she had 12 positive metastatic nodes. And that was quite a surprise. So unfortunately, even though she met every criteria to de-escalate therapy, she's now 28 years old with a pretty significant risk of distant metastasis. And so she is one of these patients that we don't really understand when she was exposed, why she developed a cancer compared to all of her other friends who were exposed, and why she had more biologically aggressive disease. So the future questions for us and what we're working on with a variety of studies is we don't really understand how individuals get this disease. We understand and we can define the populations of people at risk for this disease. For example, you know, males between 50 and 70 who've had more than 3 sex partners. But if you take 100 of those males, I don't know which one is going to get the disease and which one isn't. We don't have a premalignant model. There is no premalignant state. The way the virus incorporates into the tonsillar crypts, it's not like the cervix where we have dysplasia followed by a malignancy. We don't have a good screening test like a pap smear in the head and neck. The impact of smoking is difficult. We know that patients with a lot of smoking history have a worse prognosis, but we're not clearly defined in terms of smoking equivalent cutoffs. Cultural and racial differences. There's a lot of social issues and other things that we really don't understand about this population. The serotype we're still working on, and how do we incorporate immune therapy, biologics, and be thoughtful about our therapies. We don't want to destroy people with therapies where it leave them, you know, with a 90% cure rate, but very poor function and quality of life. But we also don't want to compromise cancer control either. And how do we stratify these trials for early stage disease when we have a low survival rate? We can't use traditional metrics all the time. So that's all I have.
Terrific.
Thank you. Thanks. Is there any questions, or we can do questions at the end? It's up to you guys.
Sure.
Otherwise, we go with Marshall.
Okay. Let me, I'm not sure how to share the screen, but we'll try and get this. There we go. Let me.
At the bottom of the screen, there is a green box that says share screen, and you click on that one.
Okay, I think I've done that. Let me just make this bigger. And I'm going to use this technique rather than the other one. Let me share it, this one. There we go. So I've cut the slides. I'm having a little trouble getting the right screen onto the right side, but let me know if you. Do you see it?
Yes.
Okay. So HPV oropharynx cancer, as Brett has mentioned, and this is really now 2020, is going to exceed 30,000 cases per year in 2025 based on projections. I think it's already past that, but that's what the projections are. This is just the oropharynx. We're now seeing it, we see it in smokers and non-smokers. So while the traditional paradigm is a non-smoker gets this, 50% of smokers with oropharynx cancer have HPV positive disease, and probably more so if the testing were done. We're seeing an increasing age now as people who were at the didn't have the cancer at the beginning of the appearance of the epidemic are now getting it in their 70s and 80s, and we're seeing people in the 80s and 90s with HPV positive cancer. As Brett has said, the prognosis is good in locally advanced disease, and up to 80% of the patients are alive at 3 years, taking all comers, including smokers and poor prognostic patients. All of the treatments, surgery, radiotherapy, and chemotherapy are highly effective, and although we don't have any good data, anecdotally, some patients are cured with intensive chemotherapy alone. Patients will survive for decades, as we know, and the morbidity, particularly of the radiation therapy and a functionally functionally destructive surgery are significant. So patients who are getting total glossectomies for this disease, or who are getting 7,000 centigrade of radiation plus chemo for this disease, are going to suffer through increasing morbidity and mortality for decades. And we see this beginning in the radiated group at about 10 years, when people start to get a lot of scarring and fibrosis, and we can see stomach tube dependence developing in those patients at that time. So our aim now, based on the biology that we know of this disease, at least in the oropharynx and not in the cervix or in the other sites in the head and neck, is to try and de-escalate at least the radiation therapy and really do a multidisciplinary treatment of this disease to reduce the long-term morbidity in the patients. A little biology. It's a very small DNA virus. We don't really know how it penetrates cells at this time. It's circular. So when it enters into the cells, it forms an episome as opposed to integrating directly into DNA. Integration is not necessary for malignant transformation, but it takes place in the majority of cervical cancer cells. It does not take place in the oropharynx as readily. So episomal versus integrated may be a biological marker of increased aggressivity in that integrated disease may actually be more aggressive. We don't know, but there's some suggestions of that. It is not restricted to the oropharynx, the anus, or the penis, or the cervix. There's vulvar carcinomas that are caused by this, and about 50% now of nasal cavity and sinonasal carcinomas are probably HPV positive, and they tend not to be HPV 16, which is the more common type in anal and oropharynx, and not the more common type in the most common, or at least the vast majority in cervical or nasal cavity. Nasal cavity, you can actually have mixed infections in the same tumor, and there are patients who are presenting with HPV 16 and 18, or HPV 16 and 6, which is a lower risk version. So we're seeing a lot of variability now that we can really measure this well with molecular techniques. So as you can see in this slide, there is a long terminal repeat in the HPV gene that allows episomal replication, and also it's within the E1 and the E2 early antigens that you see the breakpoint that inhibits those molecules inhibit E6 and E7, and when you break them up in the integration, they tend to have unbridled E6 and E7 production, which then may be one of the ways in which we see further progression of the disease. So in our attempt to reduce the toxicity, we have taken a stepwise approach. We've taken non-smokers in the SIRS trial, and in patients with more advanced disease who are not surgically amenable in the quarterback trial, and treated them with aggressive therapies, surgical therapy, and in the quarterback trial with chemotherapy, to enhance the outcomes and the control rate with less radiation. SIRS, of course, is a more elegant trial because in that trial you get the pathologic data that allows you to really nuance the therapy. And I'll show some of the data that Brett showed earlier. The quarterback trial is a little bit more of a hard hammer. We take patients with very advanced disease. They tend to have bilateral nodal disease. I'll show you some of that data. And we treat them with 3 cycles of chemotherapy, followed by chemoradiotherapy. We did a randomized trial for quarterback 1, where we 2-to-1 randomized patients to standard dose 7,000 centigrade after chemo versus 5,600, which was as low as we cared to go at that time with the data that we had. We completed that trial, and we randomized approximately 20 patients. This is the data on that group. And what you can see is that we had a very aggressive group with T4, big lesions, multiple patients with what are called N3, or a large volume cancer, as well as bilateral disease and extracapsular extension, all of which are associated with systemic metastases. Then we also had 4 patients with non-16 HPV types, 118, 2 33s, and a 35. And they were distributed evenly between the 2 study groups. At the end of the day, we had an overall survival of more than 5 years follow-up in our patient population of 87.5% in the 8 patients treated with standard dose and 83% in the reduced dose. That's really just 3 patients that failed. And all 3 of them were local regional failures. 2 were in patients with non-16 types, and 1 was in an HPV-16 patient. So we actually did what I would consider extraordinarily well compared to other studies where where patients have only gotten chemoradiotherapy. I'm not going to bother you with that data, but that data is available. This is the study looking at the combined phase 2 data, and currently we are doing we've done an additional 20 patients with just the reduced dose, and at the present time that population has essentially 6 failures among the 32 patients that we've treated, which is what you might expect. 1 failure is systemic, and the other 5 are local regional. And of those patients, we have 1 that is still alive on immunotherapy. So our overall survival is actually very, very good, with a minimum follow-up now of 1 year. So all in all, we have better survival than are reported, and these are non-smokers, of course, so that's the major risk factor that we've controlled with. This is our follow-up trial that we're trying to put in for patients who are higher risk or don't fit into SIRS. This is for patients that are not eligible for SIRS because the surgery would be mutilating, but are otherwise eligible. For patients who are smokers, that makes them ineligible for SIRS. That's groups 1 and 2 with low volume disease. Group 3 has non-HPV-16 types, as well as other groups. They'll get a higher dose of chemoradiotherapy, but still reduced. And group 4 are the high dose induction chemos for patients with 20 to 40 pack year history and larger tumors that are more prone to metastases. And this is going to be our standard of care for any HPV-16 positive patient coming in without a contraindication to treatment or some other issues such as a transplant, for example, where they're already immunosuppressed. We feel that our data is sufficiently robust to demonstrate that this should be the standard of care for patients with HPV-16 oropharyngeal carcinoma and that unfortunately the cooperative groups and the NCI have chosen not to do a definitive phase 3 trial with reduced dose radiation in any group of patients with oropharyngeal HPV. While there have been multiple phase 2 trials which has demonstrated this excellent impact, there has been and will be no phase 3 trial, as no individual small program like ours or even the larger programs can do this. We're advocating for them to do the appropriate trial. But in the meantime, we're not going to wait 10 years for them to go through their scientific agenda. And we're going to declare that this really is the standard of care for our patients. And we're going to collect this in a programmatic fashion as an SOP. And this is the study that we're going to do for the non-qualified patients for SIRS and quarterback. This is the data I'm just rehashing from Brett, demonstrating this excellent failure-free survival by the group. This is patients who have had a failure, but they're alive and well. And there were basically 4 failures. There was 1 non-cancer death. So the overall survival, disease-specific survival in the surgically treated SIRS patients is 100%. And the overall survival is 98%. I don't think you can see that good a survival with chemo-RT by itself in general. This is a new assay that's been developed by a company called Novartis, but Johns Hopkins has a similar assay, and so does Dana-Farber, showing that cell-free plasma HPV-16 DNA is highly predictive of recurrence. This is in about 115 patients in the University of North Carolina, published in January. actually published last month in the JCO. And you can see the failures in the patients who had a positive plasma test, one positive plasma test versus those that had no positive plasma test. A repeat test was done in all these patients, and if you had two positives, your likelihood of failing was immense, and if you only had one positive or no positive, your likelihood of failing was 0. So it's 100% negative predictive value and a 98% positive predictive value in this population. Just some evidence showing you that the predictions, the failures, were both in local, regional, and distant metastases. 80% of the failures with two positives had distant mets, and 35% were local and regional in this small group. And just to show you some of the data, this was one patient that they had where they demonstrated, this is all the patients on the left side showing the positives and then the development of the cancer. And you can see that there's about a 5 to 6 month difference between the two tests. This is a patient who had multiple tests. He was negative right after his chemoradiotherapy and then developed a positive test here. And what you see is that they did CAT scans rather than a PET scan. And when they did the PET scan, they identified an iliac crest bone metastases, which was not evident when they did their PET scan chest CTs, which is the most likely source. So the whole point was that this test was actually better than their clinical judgment and their clinical testing. So these are the studies that we're doing for curative treatment. We have a number of vaccine studies, including an E6, E7 study with a company called HOOKIPA, which is currently on hold for recurrent HPV-16 positive disease. And we're trying to do a study with cemiplimab for upfront treatment, which is similar to our other induction regimens for high-dose treatments. We will also be taking patients who are not eligible for SIRS or quarterback, but can be treated with a low-dose treatments and offering them a vaccine injection as part of their window of opportunity study to look at the impact of the vaccine prior to definitive therapy. So that would be the HOOKIPA vaccine. So these are the kinds of studies that we have going here. With that, I'll turn it over to whoever else.
Maybe if there is any question, and then we'll go with Angela. Any questions, guys? I have one thing with this last information about the plasma. How do you interpret this? Is this because the metastases are HPV positive, or why that plasma HPV is such a predictor?
Well, first of all, let's talk about the physiologists. Now, I haven't reviewed some of the past studies that we did, but we and others have shown that you can develop an antibody to early antigens up to 10 years before you actually have cancer, and that's highly predictive. The rate of antibody positivity goes up immensely when you get within 2 years of the development of the cancer, and this is on retrospective analysis of a large tumor bank and plasma bank from Finland, the Janus study. So we demonstrated that with Karen Anderson, and we also demonstrated the positivity of this assay in our study with Johns Hopkins. So antibodies highly predict to early antigen the development, at least in oropharynx cancer and probably in anal cancer, which are different diseases than cervical cancer biologically. We don't know about nasal cavity because we haven't really had a lot of patients and expertise in that yet. Once you have an obvious cancer, the development of something larger than a surface lesion, it's quite possible that these tumor cells are dying and entering the circulation and dying, or fragments of them are, and with them are coming the episomal HPV. And this cell-free DNA is now in the plasma regularly. Now, there may be a difference between episomal and integrated DNA in the amount of virus that gets cell-free viral particles or viral pieces that get into the DNA, into the plasma. That's not clear yet, but there is some data that you have a lower titer if you have cervical cancer than you have oropharyngeal cancer, and this is maybe well related to, and they can also begin to see how much is integrated on these assays. So this may actually predict integration, which we think is a poor prognostic feature. So there are nuances to this study they're developing. But the bottom line is that this is probably highly predictive of the development of an invasive cancer, or at least cancer in which the cells are getting into the circulation, pre-malignancy. So I think that's what we're seeing. I think very early on in the malignant transformation, you will get antibodies to early antigen, primarily to, I believe, E2, based on the data that we've seen, E2 and E7, and E2 may be an important predictor of early development of cancer, so antibody to E2. But these all require large epidemiologic studies and long-term follow-up, or at least banks that we can look at to make those predictions.
Yeah, thanks. Angela, you want to go with your, you have your slides? I think you're mute.
I would like to start by giving a background of the Mount Sinai Adolescent Health Center so that you understand the context in which we are doing this research. So this is a clinic here that is here for over 50 years. We see over 12,000 young people ages 10 to 24 every year. And we have about 32,000 who are within our age group that we have seen at least once. So it's a very large program. And it was always clinical. And within that, I would say in the early 2000s, we wanted to move into research. Something specific about the clinic is that everything is free. They don't have to have health insurance. Everything is confidential. So in terms of HPV and the vaccine, it provides a really interesting place to do the type of research to understand or eliminate some of the barriers to immunizations. For example, people often say that one of the barriers is that they don't have health insurance, so it doesn't matter here, they can come here. If the vaccine is too expensive, it doesn't matter because we give them all the vaccines that they need for free. Or the parents may not give consent. Well, we love for parental involvement, but the youth can actually give their own consent. So we have eliminated a number of the known barriers to HPV vaccine. And I think because of that, we actually have a highly immunized population. The population are basically low-income youth of color. We see everyone, the youth from the Upper East Side and the private school also come, but the majority are young people that we know have no access except for the emergency room. And we want to have a very high quality program for them and for all youth that need those services that we need, that we provide. So basically this research is a collaboration between us at the Mount Sinai Adolescent Health Center and researchers at Albert Einstein and Roswell. And we all sort of play different roles. You know, we are at the front end of the research. We have the patients, we do all the interviews and collect all the data. And then Einstein does all the testing and Roswell provides some of the epidemiological support and analysis and things like that. What we wanted to look with this research was to see the impact of the vaccine. If young people who are vaccinated then have lower incidence and prevalence of the HPV type vaccines, and also if they had lower cervicocytological anomalies. Another interest of ours is to look the cervicovaginal microbiome and to see the association of that with sexually transmitted infections and more specifically chlamydia and HPV. And then we have an interest just on behavioral things. So we wanted to know the association between psychosocial factors and high-risk sexual behavior and the microbiome and HPV infection. The inclusion criteria are, this is a female-specific study and adolescents. So to enter, they have to be 12 to 19. They have to be sexually experienced. And what I mean by that, if they have had a history of vaginal or anal intercourse or both. and they have to be among our patient population and had either received or had decided to receive the HPV vaccine. And exclusion is if they were currently pregnant, but they can join 6 weeks after the outcome of their pregnancy. And if they were not sexually active or had neuropsychiatric disorders that made them impossible to really understand informed consent. This is a cohort. We began in 2007. And the reason that I began this research is because prior to the vaccine, around 2006 or so, I did a pilot and I tested about 100 girls from the mouth, the cervix, and the anus. And this is pre-vaccine, and 59% had HPV in the cervix, 57% had HPV in the anus, and 12% had HPV in the oropharynx. So we knew that it was a very high prevalence. So that's why I decided to apply for this research. So we began in 2007. We see them every 6 months. We are following them as of now until age 30. And we collect specimens from the cervix, the anus, and the oropharynx. Also, we are collecting blood tests for antibody testing. And they do a number of questionnaires, including demographics about schoolwork, sex and reproductive health, depression, history of trauma, use of substance, peer deviancy, and HPV knowledge. The youth, the majority are age 17 to 19, but that was because even though I designed the study to be 12 to 19, when the vaccine came to the market, there was a lot of political controversy about the right of youth to get this vaccine or not. And Sinai initially only gave me the permission to see young people who were not minors. So they had to be 18 and 19. So that's how we began. And eventually we were able to change to be able to get young people who were younger, first 14, then even down to 12 to participate. But that's why the majority are the older group. The race ethnicity of our youth, the majority, almost 60% are Hispanic, and the large proportion are also African American. That's just a reflection of the young people that we serve. And they are all, to be part of this research, they have to be sexually experienced, and most of them have had at least 4 sexual partners by the time they enter the study. This is to give you just a baseline. This is after the vaccine was approved that we began the study. This is the baseline. And at this time, most of them were not vaccinated because this was at the very early 2000, very early, so they were not vaccinated. And you can see how prevalent HPV is in our adolescent population. And it's all type of HPV. And this is in the cervix, the anus, and the oropharynx. So very high prevalence of HPV in this population. This is to show after, all the way, this is cervical and anal, all the way to the left is the unvaccinated. So those are the proportion of HPV 6 and 11 in the yellow. The blue is HPV 16, and the green is 18. And once vaccinated, it has a tremendous decrease. And even if they get less than at that time, this was the quadrivalent vaccine that they have to take 3 different doses at times 0, 2 months, and 6 months. So even if they didn't have all 3 doses, you have a tremendous decrease in the virus. And that was true for cervical, and it was also true for the anal. And this is the oral, just also very similar impact, tremendous decrease once vaccinated. The proportion of cytologic abnormalities associated with vaccine type has declined tremendously since we began vaccinating in 2007. And you can see here in terms of the proportion, the blue is before the vaccination, and the yellow is the amount of cytological abnormalities that we are seeing once vaccination began. And that is true for the, at that time, the quadrivalent types of HPV virus, the 6, 11, 16, and 18, but also 31 and HPV 45. You can see that. So even though the vaccine has tremendous impact in decreasing the amount of HPV present, this slide shows that if a young person is 15 years of age, so the older they are when they get the vaccine, and also the longer they take, if they take more than 12 months to complete. I mentioned before that the vaccine is supposed to be 0 to 2 months and 6 months. So for some youth take, 12 months or longer to complete. So the older they are and the longer they take to complete, there's less effectiveness of the vaccine. You don't see as large a decrease, even though overall it's lower than the unvaccinated. And that is also true for the previous one was about those cytological changes. Here is the HPV that we find. So, we realize from this that the earlier you get immunized and the more timely within the schedule that the vaccine is supposed to be taken, the better, the more protected the young people are. The other things that we realize is that we actually, as we enroll the young people, we do a knowledge survey. We do a lot of teaching in the clinic about all type of things, including HPV, so that the youth understand and have the information. And what we found was that the more knowledgeable they were about the vaccine, the more likely they were to complete at that time the 3 doses within the recommended time. So, it's an area that we can, the more we know that by teaching them about HPV, helping them understand, then that can really help improve the immunization rates of HPV. So that's all I have right now.
That's great, thank you. And any questions? This is very interesting study. Do you follow them, Angela, over time, or these are just kids that go at a certain point?
No, they're our patients, basically, and they can start here at age 10, but they can enter any age between 10 and 22, and they stay to 24. To be in the research, they have to be 12 to 19 to enter. And now we are following them basically into adulthood, into 30 years of age. And we see them every 6 months. We repeat the studies, both the biological and the questionnaires. And we follow them. And this group is 100% immunized, because to be in the study, they have to either be immunized or had agreed clinically to get a vaccine.
Because I'm just wondering in the follow-up, you have reduced the rate of infection. You don't know if, being a minority population, you don't really know if you're preventing cancer occurrence, because the HPV types may be different in terms of oncogenicity, depending with ethnicity. So it would be nice to follow them up longer.
Yeah, right now the present 5-year funding that we have is to go to age 30. We'll see. It's hard because I need to sort of negotiate. This is an adolescent or a young people clinic. So for the research, we are going older. So, I need to negotiate that with the chief medical officer and just figure out how we do it so that the clinic still is a clinic for young people or younger people. Yeah. So but I think it's very important to continue to follow this cohort.
Yeah, absolutely.
So I had a question for you, Angela, about, this is probably one of the only times I can remember where there's almost what I would call I guess a reverse disparity. So we see this disease in head and neck in white males of upper socioeconomic classes. And if you look at the vaccination rates in New York City, the vaccination rates are much higher in minorities and ethnic populations. So they're actually getting better penetration of the education and the vaccine due to the schools requiring it and your educational efforts and all this stuff than we see in the young white adolescents. And so the actual, from the head and neck standpoint, the target population, or the people that are getting head and neck disease, are the ones that are not being targeted for the vaccine strategies or for other reasons. I wanted to get your thoughts on that, because it's usually the lower socioeconomic classes that have the problem with penetrance of these initiatives, but it seems to be opposite in this specific instance.
Yeah, you know, so one of the things that I have discovered, at least with some of my friends, is that when they take their children to the pediatrician, the teenagers, some of the doctors were not recommending this or bringing it up. And one of the major determinants of parents immunizing their children is a recommendation from the physician. So that's something that we should, I mean, I just said to my friend, go back and tell your pediatrician that, or, you know, but I think that's a major opportunity to actually, because many of the private pediatricians have patients who are the upper, you know, class white, the population that you are referring to. So I think there needs to be more of an effort in addition to targeting the population to understand the importance of immunization, to also target the physicians themselves. And you know, some very few parents, most of the youth can come here by themselves. And initially, the way that the law was written in New York and in most of the US is that even though adolescents have the ability to consent for their screening, treatment for sexually transmitted infections, the only way they could get a vaccine, the HPV vaccine or any vaccine, was with parental consent. So we worked really hard at changing that law. We were very involved. And now the youth, I mean, we love parents, the parents can consent for their youth, but those that do not have that opportunity or need confidential services, now they're able to get it without any issue. And we're always proponent of that, but other places, even Planned Parenthood, that is really progressive, were not giving the vaccine at that time. So that helped another layer of facilitating vaccination. But I think we also need to continue to work with the people in private practice and continue to work with the parents and just really encouraging this.
Yeah, and I would just point out too that something that's interesting is that your point about physicians not bringing it up. One of our residents did a nationwide study surveying medical students in their third and fourth years. And over 50% of them understood that HPV was a risk factor for cervical cancer, but only a very small portion of them understood it was a risk for other cancers like anal and head and neck cancer. And so I don't think we're doing a great job educating our physician force to even know to talk to an adolescent male about getting the vaccine. I don't think these physicians that are currently in practice really understand that. So that's something else to target too.
Yeah, no, that is true. And I think I met with someone from Sinai that was doing some of those interviews. And that's another population that needs to be targeted. And there need to be more awareness, as you said, about the association of HPV with cancer of the oropharynx and other areas. Just even in the general public, because people now understand the cervix and HPV, but I don't think that people are so aware about the anal, the oropharynx and other associations.
Interestingly enough, at least in the quarterback trial, we are getting a large fraction of Hispanics and African Americans. That would be unexpected. We don't think that there's a biologic reason why they don't get it. We think it's more cultural than anything else in terms of oropharynx cancer.
How about the risk factors? Because probably smoking and drinking is different with race as well.
We haven't done a broad risk factor assessment of patients. We do a good smoking history, and
Okay.
part of the mouth study that Brett is running is a sexual history, but we don't take much of a sexual history when we are evaluating
Yeah.
patients with advanced disease. So.
Right, because I feel like behavioral, the behavior is very different probably across races, and probably smoking in Latinos is not very common in general yet. And
You know, but oral sex is very common. I mean, at least with our youth, an anal sex. Also, like 1/3 of the youth are having anal sex, and many of them are having also oral sex, and they are Latino and African American.
I think there's going to be about a 20 to 30-year lag in seeing the
Mm-hmm.
cancer in this current population.
Mm-hmm.
So we may be talking about what's going on for the last 20 years, but we may not
Mm-hmm.
see it for
Yeah.
another 10 to 20,
Mm-hmm.
especially if they're not being vaccinated, because we don't have that kind of sexual history is available, but I think it wasn't as broadly applied here in this country as it was, say, in Europe. We did do in the hotspot study, we did a very deep history, but again, that was a study of spouses of patients with HPV positive cancer as well as the HPV positive population. So,
You know, we have very thorough sexual history. I mean, we also do that clinically, but we also in the research, and we are also immunizing the males and the transgender. We have over 600 transgender youth. We immunize, you know, we work really hard at educating them and helping them get immunized, not just against HPV, all the vaccinations that they need.
it'd be good to have a group get together just to talk about the different populations that we're treating. You're treating adolescents and mostly women. Keith is treating adults who have HIV. We're treating oropharyngeal adults and other head and neck sites adults. It'd be worth kind of sitting down and just talking about what we're generally doing individually and together. I mean, we're very interested in antibodies, but I don't have a collaborator anymore who's doing antibody testing, although it's relatively simple. And we are interested in molecular diagnostics, particularly plasma tests. So, you know, as you start to screen your population for cancer, it might be worth connecting with one of these companies to see if their assay might be part of your research evaluation. Same with Keith. Does a cell-free DNA indicate a risk for invasive anal cancer or invasive or more profoundly difficult, disturbing cervical disease?
that would be a good idea, actually, to meet and make a list of things. Yeah.
Yeah, I think we could even set up a session at the HPV working group just talking about populations. You know,
Yep.
Great. That I
just
would
have
like that.
everybody present about, you know, populations that they're treating and maybe, you know, what type of molecular diagnostics could be integrated in that. Because I think looking forward in the future, that's where we're going to be going, right? We're in this kind of quote dark ages where we don't know what causes the disease, and then we wait for a lymph node to pop up in the neck, and then we do a bunch of CT scans hoping we can find out where it's coming from. And that's not where the future is. The future is going to be, you know, these types of things like cell-free DNA and blood tests and biomarkers. So might want to be able to have some data on that. So maybe I'll put that on for the agenda for the HPV working group at some point after we get off this COVID issue.
Yes, and on the side, beyond Liu is also looking at HPV vaccination, looking at the enhanced database. So she has more of a large database population eye. So maybe we can involve her as well. She does a little bit of this. And it's not her main area, but she has done a little bit of that.
I have a question for Angela. There's some evidence that even though you have a positive smear for HPV, that you reduce the risk of cancer by giving the vaccine. Do you feel your data supports that? I mean, you have very robust data that you reduce the incidence of HPV and presumably high-risk HPV if you give the vaccination in those people that already have it.
Well, so far, like none of our youth had it to begin with, but we saw a major impact in high-grade ACL, all
Mhm.
those cytological anomalies. I mean, we used to see tons and tons of them and do endless biopsies and, cone surgery and cryosurgery. And it almost like it got so low that I cannot tell you. The other thing that could almost completely disappear was venereal warts. We used
Yes.
to teach endless venereal warts. We were always treating them. And now we don't even see them anywhere in the body.
That's great.
So huge impact in those things.
That's a major publicationable piece of data.
Yeah.
Yeah, that's great. Well, I got to run to another meeting, but thanks so much.
Thank
Okay,
you.
thank you
Thank you.
Great.
guys. Yeah,
Thank you.
thank you everyone.
Bye-bye.
Bye, bye guys.
Bye.